the knee replacements these days are top notch, and you can do a bit of running on them. You can ski. You have nearly a full active life with them. So
Interesting.
it's a long
Yeah,
way of answering it.
there was so much information. I still have questions about that because when I
Mm.
was getting my hip replaced, everybody's like, "Oh, it's very simple. Don't worry." Knees, oh wow, that's like a lot more complicated. And I guess what I never heard what you're saying now is actually saying, "Well, it's not as complicated anymore." Maybe that's what it was.
Well, I guess if you're an orthopedic surgeon who specializes in hips and knees, they would probably say neither are complicated per se.
Mhm.
But I would say that the technology with the prostheses and the surgical approaches to a knee replacement is much better than it was 15 years ago.
Welcome to the replay, everyone. It's this odd hour, so maybe you guys have not been able to come and show up, but I'm so excited to introduce you to Panda Li, who I met in person in Hong Kong, and she's been recommended by a very good friend of mine who trains with her and sees her for her own issues. But we're going to talk about the musculoskeletal system, what happens in menopause, and answer your questions about your joints pain and your injuries and all that stuff. So welcome, Panda.
Thank you for having me.
Let's hit with the first question. We'll leave mine last because I gave a bunch of questions, but mine is quite thorough. But everybody who knows me, well, everybody in this group knows I just had hip surgery. So we'll leave that to the end because I know some other
No
women
problem.
as well here are considering it as well. So first question is, I'm 50 and freaking out that I have been told I have osteoarthritis in my knee. A friend of mine recommended I try Shockwave therapy. There's a clinic here that uses a machine called magnetolith. Do you have any idea what this is and if it's effective for my condition?
Okay, so let's just assume that most people know what osteoarthritis of the knee is, but for those who are unsure, it basically means that you've got wear and tear of particularly the cartilage, and sometimes when it's severe, the bone itself. So that will cause joint pain, inflammation, swelling, and limited activities, particularly things like stairs and walking long distances. And sometimes when it's really bad, it even hurts when you're just sort of sleeping or walking. So let's break that question down to a couple of things. Firstly, the Shockwave and the device, I forgot the magnet machine,
Yeah.
they're actually two different modalities. So the actual Magnolith machine is what we call EMTT, which is electromagnetic field and therapy. So it's using magnetic therapy to create a field to affect the joint. It is reputedly known to help with inflammation, pain, and regeneration, restoration of tissue damage. Now that's been around for some time, but it's come more back in vogue, like many other modalities in recent years. And although my knowledge may not obviously be extensive and everything that's out there, but from my sort of recent understanding and readings, there isn't as much strong clinical data to support its efficacy. On the other hand, the ESWT, the extracorporeal shockwave therapy, has more long-standing clinical data to show some efficacy. There's different types of shockwave, and just to reiterate again, the shockwave is different to the EMT, which is the Magnolith machine that this lady has asked about. So the shockwave therapy, again, it was originally used for two conditions: interstitial cystitis, which is an inflammation of the bladder, and also kidney stones. So what shockwave therapy is actually sound waves, so acoustic waves at different frequencies depending on the type they use, to break down the kidney stones so that you don't need surgery and the kidney stones are passed through just urinating. They've found that this type of therapy has had effects for musculoskeletal issues, for osteoarthritis, through working as an anti-inflammation mode, also tissue regeneration. So it helps remodel the tissues by creating osmosis of, let's say, the healing cells versus the damaged cells. Again, as with all clinical data, you will find data that supports the use of it and equal amount of data that does not support the use of it. And, we won't go into the discussion of how clinical studies are done, but how those studies are done are quite important. And I would say there's enough evidence to probably support the use of it. However, having explained all that, personally, as a sort of manual therapist and clinician, and been doing this for some time, I would use a Shockwave or EMT, and particularly maybe I have a slight preference to Shockwave as an adjunct rather than the core treatment modality of itself. As with any osteoarthritis of any part of the body, whether it be that your hip, knee, or lower back, my first question is always, why is that area of the body being loaded more excessively than any other region of the body? So, for example, if you've got osteoarthritis of the right knee, if it was just, let's say, aging and general wear and tear or menopause or all these other issues, why is it not both knees equally? And the answer is that usually we kind of look symmetrical. We've got two arms, two legs, but we really aren't. Most of us have had a life, other injuries, our bodies compensate, and we end up wear and tearing a specific area of the body. And in this case, this lady's knee. So my first approach would actually is look at the person, listen to their story, their life. What do they do? What's their exercise life like? What's their emotional stress like? All these factors, and then ascertain what their physical status in terms of how they load that knee. So my approach would be a very comprehensive, holistic approach to really see, even though it's a knee joint problem, why is that person, loading through that knee too much? Or on the contrary, are they not strong enough in certain muscles to support the knee? Or are they doing activities that are beyond their scope of abilities and have worn it out excessively? So modification of lifestyles as well. So in short, those therapies can help, but I really think that they're short term, if any, and maybe some help with pain relief. But I think long-term pain management requires more input from a therapist, a good therapist, who really can look at the person in a holistic manner, and also the patient themselves to really put in the time and effort. But ultimately, if you ask me, there's been great advancements in knee replacements in the probably last 5, 10, 15 years. If you'd asked me 15, 20 years ago about osteoarthritis in the knee, I would have said, hold off as long as you can. The surgery is very painful, but the results are okay. If you're in severe pain, it's great. But if you're you're in enough pain and it's limiting your lifestyle to be fit and active, which is also very important for the rest of your health, I would have said hold off. But now I wouldn't. I mean, of course, you hold off for as long as you can and as reasonable as possible, and obviously with the advice of your orthopedic surgeon. But the knee replacements these days are top notch, and you can do a bit of running on them. You can ski. You have nearly a full active life with them. So it's a long way of answering it.
There was so much information. I still have questions about that, because when I was getting my hip replaced, everybody's like, oh, it's very simple. Don't worry. Knees, oh, wow, that's like a lot more complicated. And I guess what I never heard what you're saying now is actually saying, well, it's not as complicated anymore. Maybe that's what it was.
Well, I guess if you're an orthopedic surgeon who specializes in hips and knees, they would probably say neither are complicated per se.
Mm-hmm.
But I would say that the technology with the prostheses and the surgical approaches to a knee replacement is much better than it was 15 years ago. And for example, there is both hip and knee, there's robotic assisted surgery, which minimizes the extent of the scars and the amount of soft tissue damage so that the recovery is quicker. Surgeons are now able to personalize the surgical plan according to the person in front of them. So, moving into what we call probably medicine 3.0 rather than medicine 2.0, which we, is used for the general population. So it's much more personalized and customized. And, as part of that plan, they often are able to now make customized implants. So before, as with a lot of health studies they're often on white males. Obviously, you're not a white male and we're not the size of white males, and neither is, 2/3 of the Asian population. So now they're able to customize implants, and they come in different sizes for different people. So that's a game changer as well in terms of how it fits. There's no loosening of the prosthesis when it's in. So much better. And as I said before, they again with hips as well, not only do they use sometimes robotic assisted, but they use what we call minimally invasive surgical techniques. So again, minimize how much they have to open that joint up to gain access, but still produce high quality surgery. So obviously these skill sets are very specialized to the surgeon. So these are maybe questions you may want to ask the surgeon, whether they're, good at these or how many have they done, to ascertain the experience and whether they're a good fit for you. The other things to know, they have a modular component now. So in the old days, it was sort of just a couple of bits put together. And if they wore out, they'd have to remove the whole thing and put the whole thing back in. And that's very traumatic. And what we call revisions, which is doing the knee replacements again, had not great outcomes. But these days, they leave the hardware, like let's say the stuff that goes into your femur, into the femoral head and the tibia, but the let's say the where the cartilage was, they're able to change those components. So they're often made of, high grade sort of levels of plastics or different kinds of modern prostheses. And when they wear out, if they wear out, then they don't have to take all that hardware out. They literally go in and just take out those modular pieces and replace those ones. So the surgery is much less traumatic, faster recovery, and you can keep changing those components. So again, really, really good advancements in techniques and surgical ability. So, what used to be oh my gosh, my active life with osteoarthritis of the knee is now over, is now it's a game changer. It's great. It's like, yep, okay, let's get it done.
Yeah.
And they last more than 20 years easily, recent studies have shown that they last quite long. Whereas the old ones, 10, 15, 20 years maximum, you're probably looking at a revision. So it's kind of okay to get them done a bit younger now too as well, assuming you may need a revision, but that would be 20 plus years. And so, yeah, generally speaking, of course, my first approach as a physiotherapist is more conservative management, be aggressive with their whole body health and how we can make lifestyle changes with that. But, at the end of the day, we have modern medicine, and surgery sometimes is the best answer, especially when you've exhausted all sort of other avenues that are available to you.
Mm-hmm. I like your approach of looking at the whole body and why are you wearing down your knee anyways in the first place? And interestingly enough, if this is interesting for anyone who's listening, I had an ACL tear 30 years ago. And on my right knee, and I never had a problem, slippage, yeah, but never felt pain. Don't have osteoarthritis there, but I have the osteoarthritis of the left hip. And so I was probably compensating the last 30 years, probably micro movements that I didn't even notice. And here I am. And maybe that's so people are like, why did you get this? And I don't know, maybe that's one of the clue, but could have been in a bit of an imbalance. And I find it, that just to support what you're saying is perhaps, that could be.
Yes, absolutely. And that's I guess, the sort of art and science of, I think, what we do is to be able to look at the different components of the physical body, but listen to the person's story about what their body likes, what their body doesn't like, and weigh in those factors to see what is actually really causing the problem. And in my experience, and I've had some patients with terrible MRI findings of their both knees, on what we call grade 4 arthritic changes, and all good faith, the surgeon has said, look, you need surgery, and that's definitely an option. But once I'm able to really assess their whole body and find out what's going on, you often can alleviate a lot of their pain, and actually they go back to a really good level of function. Now, obviously, if they're a severe grade 4 osteoarthritis, it might be such that, you've bought them pain-free time for a few years, or actually they're happy to modify their lifestyle and prolong the surgery. But in any event, I think that for the maximum benefit of your surgery, which is expensive, time-consuming, and can be, a lot of hard work, you want to maximize how effective that is by making sure all the rest of your body is also loading through that joint well, and to be able to maximize your ability to strengthen the muscles that now need to support this new knee or hip or whatever.
Yeah. So as anyone who is considering surgery, I think, to me, my objective was, let's try to get as strong as possible so that I maintain muscle mass and I can be there so that for a faster recovery rather than just let it all go. I was very limited, and I understand anyone who's in pain, you're very limited. But there are ways, and working with a physio like you'd find ways around that and in order to prepare for the surgery.
And I think that one of the good things about our profession is I think we know our limitations. And so, I think that once we've sort of established that in our scope of practice, we've done as much as we can, and, whether that's involving other therapists as well, but certainly to advise patients, say, listen, if you want to do A, B, C, X, Y, Z, the next step is surgery, and that's maybe what you need.
Yeah.
And then, referring them on.
One question about the shockwave therapy, is that painful?
It can be, actually. It depends on the type you get. There's radial or focused, and radial, as the name suggests, is more of a larger area, whereas focused is more like a small, let's say, tennis elbow or Achilles tendonitis, small areas. So the wavelengths and the frequency and the dosage can be different. And so, yes, some of them can be quite painful. That is the truth.
Yeah. Okay. The one question about the knee, in case this, again, helpful for people and be interesting to hear your opinion. I had platelet-rich plasma injections in my knee when it was like slipping a lot. And again, I'm doing exercise as best as I can, maybe not properly. I don't know why it was slipping, but I did get that, and that's helped a lot. And now it's been 2 years and I haven't really been using it. So like, let's see when I get back. But I also did PRP for the hips years ago. And again, like it seemed to me every year and a half, I'd have to have a new one. And again, my PRP also included hyaluronic acid. So I don't know if it's PRP or the hyaluronic acid, but I bought myself 9 years because I was first diagnosed in Hong Kong when I was living there. I had a hip impingement. I had a, deadlift and hurt a snap. And they told me, yeah, you need surgery. And I'm like, well, I don't know. It just seems a little early. And I started physio. Physio helped a lot. And then, doing all my hacks. And I think I bought myself time, but it would be interesting to hear your thoughts on platelet-rich plasma and or hyaluronic acid for people with this kind of issues.
Well, the good thing with PRPs is that there's minimal side effects. I guess the main one is infection, but because you are breaking the skin barrier and therefore introducing potentially an avenue for bacteria or whatever to get in. But by and large, there aren't that many side effects, and that's mainly because obviously you're using your own blood, and they spin it and they get the platelets out of it, and then they inject that into it. So there's no foreign tissue per se. In my personal experience, it's really 50-50. Some people have your story. In my experience, most people don't, but that might be because I see them when it doesn't work. If it worked, maybe I don't see them. I think that, again, so PRP works in the sense that it helps stimulate regeneration of cartilage, and it's an anti-inflammatory and therefore an analgesia and reduces pain. But again, with conditions such as arthritis, it is about the surfaces rubbing in a way that they don't want to be. So the cartilage wears out and you get drying up of the joint fluids and things like that. Ultimately, again, the question is why are they rubbing? Why is that rubbing more than the others? And often what you find is if you take that reason away, your body heals. Your body wants to heal. It knows what's good. So if you are able to adjust the scale where the rate of damage is less than the rate of healing, and the rate of healing is greater than damage, then what you often find is that you may not need the PRP, but if you do get it, you're going to optimize your chances of the PRP working to stimulate that cartilage growth, because now they're no longer rubbing. So I guess when I explain to my patients, if the PRP is stimulating cartilage to grow, cartilage doesn't grow overnight and become solid tissue structure that quickly. It takes time. So in which case, then you want to stop the surfaces from rubbing so that the gel or the cartilage formation has time to form its solid matrix. And if it forms its solid matrix and you don't wear and tear it at the same time, then you're going to optimize your chance of protecting that joint and alleviating your symptoms. So I think always my first thought is, well, what are the downsides? And there aren't really that many downsides with PRP, truth be known. There may be expense and the small risk of infection, very small though, versus the upside. Now, the upside, it could be that it really does help. So in that case, on the balance of things, I would support what my patient or any person would want to do, inform them of the potential, and yeah, there isn't really a huge downside, so why not?
Yeah, when I was researching it, I found it was about 50 to 70% success rate in some of the research, but more often than not, yeah, it seems it coincides with a bit what you're saying as well. So it's kind of a hit and miss. It's an expensive hit and miss for some people, depending where you are in the world. But if you really want to avoid surgery, it's worth a try. So
yes, I would agree. Yeah.
Yeah. Okay. Now let's move on to the next question. I have a bunion on my left foot that doesn't bother me too much, but I'm worried about it getting worse as I age. I'm now 53. I stopped wearing narrow shoes and go barefoot most of the time. I got some toe spreaders, but I have no idea if these work. I remember my mother suffering so much with her bunions, and I don't want to have the same fate. Do you have any other recommendations of what I can do?
Yes, absolutely. The feet are so important, but yet so neglected. We all think that they're just these appendages that occur at the bottom of our legs. And, the most we take care of them is to actually probably get a pedicure. So they really do need to be looked after. Firstly, that approach has been so far really good, where she's got rid of the things that cause or part of the problem, which is the tight shoes. And now she's trying to get some spread in those toes and she's getting toe spaces. That's great. Tick, tick, tick. And bare feet is good too, because it again allows your feet to work what that we've been bipedal for tens of thousands of years, if not hundreds of thousands of years. And so we are proprioceptively designed to activate our muscular system on our feet. So to give as much sensory information to our feet as possible is very important to stimulate the muscles of our feet. So going barefoot is good. The problem is that we've been in shoes for a very long time and we've dulled those senses, and a lot of the time we wear shoes that are inappropriate. So for example, too tight or the sole is too hard. And so the muscles and the joints of the feet, and therefore the rest of the whole body, in fact, don't get the opportunity to work the way they should. So barefoot's great. And obviously you do need to wear shoes. So the shoes that I would recommend are a type of shoe called a wide toe box shoe. They are more common now than they used to be. There are certainly a number of, let's say, running shoes or sports athletic shoes that have this wide toe box. The next aspect of a shoe would be what we call the zero heel drop, which means that the height between the heel and the forefoot is flat. So like a pair of sandals or flip-flops or thongs, whichever country you come from is what they're called. So where the feet again really get to feel the ground. And next to that is what we call the stack height, which is the level of foam that you normally find on sneakers. To have that as near zero in terms of functioning of the foot is best. Now, if you've gone from used to wearing high heels, tight shoes, or big padded soft trainers, depending on that person's stature, their lifestyle, how strong they are in general, as to how that process would occur to wean down to that. Because it would be the equivalent of, let's say, someone who doesn't run to say, well, I would like to do a marathon next week. You're going to be in a lot of pain. So you've got to wean down each process depending on, and preferably guided by someone, or Google the search and how you can wean down to that optimum sort of footwear. The reason why those are important is because there's a mechanism in our feet that when our feet, our toes are allowed to splay, and it triggers a stiffening of what we call the plantar fascia under our feet, which is like a thick, strong ligament. And this thick, strong ligament has lots of little foot muscles, which we call the intrinsic foot muscles, attaching to it. Now, when the foot is allowed to splay and do its job, it triggers the plantar fascia to tighten. Why that's really important, and this goes to your ACL slippage, as you were calling it as well, is that it triggers the calf, and your calf is one of the strongest muscles in your body. In fact, the tensile load of your Achilles tendon is gastronomical. It's super, super strong. You're not going to find, you can't actually fabricate an artificial synthetic tissue as strong as your Achilles. And it triggers your calf to pull on the Achilles to give you that push off action mechanism that your foot needs to propel you forward. So when you wear shoes that aren't triggering that, or the muscles in your feet are so weak that you've lost that mechanism, then you are really putting excessive loads throughout your whole body, but more closely related to your, let's say, your knee and hip for starters, and even your lower back. So that slippage of your ACL reconstruction, the role of the calf, one of the roles is to stop that, what we call anterior translation of that tibia or the shin bone going forward, and that's the role of the ACL. So if that mechanism's not working, you are causing a bit of shearing in the ACL. Now, I'm sure your surgery was excellent, so therefore it's holding that and withstanding that force. But going to your original point of, am I compensating for my left hip for my right thing? Well, it's all about percentages. If you've got 10% here, 5% here, it all adds up over many years to wear and tear somewhere else. So to summarize, the toe spaces, what the research shows is that if you wear wide toe box shoes and toe spaces, that is as good as doing some specific strengthening exercises, particularly for your toes and your feet. Now, clearly, both is best. You're going to get optimal results with both. Now, with the lady's bunion at this stage, from memory, it doesn't say that she gets a lot of discomfort, but she just wants to prevent that scenario. Then what she wants is to prevent it from getting any worse. Now, the reality is, unless you have surgery, and surgery is another whole discussion point, they can't seem to agree on what is the best surgery for bunions. So really, we're unlike knee replacements or hip replacements, I think with bunion surgery, avoid it at all possible roads if possible, because the outcomes, surgical techniques, I can't seem to agree which is the best. So as I say, there are specific toe strengthening exercises which then tie in with feet and calf exercise, strengthening exercises, very effective in triggering that response that I've just said, and also preventing that bunion from getting worse. And in fact, not necessarily improving the bunion, but improving the position of that toe, so that it doesn't sort of give that crossover of that, what we call when the hallux toe goes over the second toe. So to prevent that from happening, the combination is of both is best. And there's many YouTube videos on some of these exercises, but the one that I think is particularly good is a website, and she's based in the US, called Gait Happens, and she has quite a number of YouTube videos and Instagram, whatever else, that I think show very effective foot exercises in combination with the shoes and the toe spaces. So the toe spaces do work. They do work. In fact, I recommend most people wear them because most people have some sort of degree of foot issue, to be honest.
Can you wear them inside the shoe?
Absolutely, especially if you're buying shoes that are particularly the wide toe box shoes, or when you're at home in your bare feet. There's no reason why you can't wear them then. And it's a bit like everything else, should we have 100% pure, clean diet, whatever that means, and never have a glass of wine or never have a piece of chocolate? Well, not really. I think your body can tolerate some, degree of naughtiness. And that goes the same with your shoes and exercise and footwear and things like that. So I guess it's personalized as to how much your own body needs or can tolerate and what that threshold is.
So can you reverse bunions?
No. You cannot reverse the size of that bunion, but you can reverse the symptoms that it's giving you. So again, it's about, there's also a difference between bunions and hallux rigidus. The hallux is just the big toe. Rigidus means, as the name suggests, a rigid, stiff toe. And they are different diagnoses. You can have both at the same time, but you may just have one and the other as well. So what's really important is to make sure that if you've got hallux rigidus, which is where you've got very limited movement of that big toe, that you do see a therapist to regain that range of movement and then strengthen the foot to further, or in this case where your lady has not got symptoms, to maintain it as is.
Super interesting. Okay. I was always on the fence whether those toe spreaders work or not, and they're not expensive, and I mean, give it a try.
I call it low-hanging fruit. It's almost a pretty pink pill, almost, where you just put them on. They're not expensive. What I would say is that some people find them uncomfortable to start with, and that's because they're literally stretching your feet and stretching in a way that it hasn't used, and you're using your feet now and just even walking in a different way. So there is going to be some soreness. So what I would say to people is build up to it. If you wear it for an hour and it hurts after that, well, then take them out. And the next day aim for an hour and 10 minutes or an hour and a half or whatever that threshold is. And what you find is, over whether it's days, weeks or months, it doesn't matter, you'll be able to wear them all day and not really notice them. And so, that you will literally see the shape of your feet, the shape of your toes really change.
But
especially if you do the combination.
But it must take years, right?
No. I think that your body's actually hard driven to do the right thing. It knows what is good for you. And so if you encourage it and support it in a way that's encouraging it to do that, it will. The uptake is quick. Now, clearly, the longer you've had a problem, the longer it will take. But if you do a combination of self-manual release and stretches, the strengthening exercises, the shoes and the toe spaces, you'll be surprised how quickly and how effectively that can change.
Wow, that's great news. Okay. Very simple techniques. Okay. Let's move on to the next one. This question is from my mom, but I hope you can help. She has a spinal cord injury from a car accident 20 years ago and has recuperated pretty well, but she still has residual pain down her back and even down the legs. What do you recommend she try?
Wow, I'm going to answer this one a little bit more generically because I don't know the age of the mother, any other comorbidities. And when someone says spinal cord injury, I mean, are we talking just some spinal cord compression, or are we talking about any severance or any other joint structure damage? So I don't want to make guesses that are not accurate. So someone like herself, I'd ask her, what is her current exercise history? What is your lifestyle? And also to really ascertain whether it is actually still from that spinal cord injury, or is it just something else, actually. So asking her specific questions about what her aggravating factors are, what relieves it, what actually, when did it start, all those historical questions really help me ascertain whether it's the spinal cord injury, or actually, no, it's a weakness of her glute muscles, or her sacroiliac joint isn't in a good position, or actually her upper back is really stiff and it's causing her to use her lumbar spine more. So therefore, it's got nothing to do with the original spinal cord injury. So that's the first thing I would do, is actually have her assessed again by someone who's going to ask those deep questions, deep questions that really dig and find out what's going on. But again, let's assume that she's a mother. So let's assume she's 50 plus. I think that we can, make that generic assumption. And I'm assuming that because of her pain, she may or may not do too much exercise. But the focus there would be to try and exercise to the best level that her body allows. So not pushing her through pain or anything like that. In fact, exercise that's good for you, you may feel muscle pain, but not your symptomatic pain. So that's very clear, to be sure that when she's got a rehab program. So someone like her, focusing on her balance, her stability. And I'm going to say this, definitely her foot strength, because that is what gives you balance and stability when you're standing. And just FYI, falls are the number 5 killer in the first world countries. And so prevention of falls is not a small, insignificant factor in that. I'm going to say core work. Now, I know that means many things to fall, but core work to me means a combination of her trunk core muscles, like the abdominal ones that everyone kind of knows about, some back ones, her pelvic floor, and actually your diaphragm. So that would also include breathing techniques as well. And this is the other thing, if she's, under a lot of emotional stress or load, what you find is people are very tense, particularly in their upper back region. And if that becomes really stiff, then you do tend to load through other parts of your body. So if that's one of her big drivers, then, addressing that with, upper back stretches or mobility things or meditation or breathing, whatever, again, goes at the root cause. Now, I'm not evading the fact that it's a spinal cord potential injury, but if it truly is a spinal cord injury that happened 20 years ago, any of the healing from the direct trauma has already occurred. And what's left is anything that was maybe injured as a result or another problem. So again, addressing anything that's contributing 5% here, 20% there, 15% here, 10% here, because fundamentally we may not be able to change that central other part. But if you are able to change 50, 60% of the other mitigating factors, then you're going to make a real difference to that person. So, in summary and in short, I would ensure that she has a exercise program that's tailored to her abilities, and that actually you do keep challenging her body and keep that challenge, rather than just say, look, I'm going for a brisk walk every day. And that's great. But, do some strength training, push the boundaries a bit to get those muscles stronger to support her body.
Great answer, considering you didn't have much
and of course,
detail.
Yeah. And of course, manual therapy. I just don't think you can beat a good manual therapist. I think a lot of therapists these days have, for whatever reason, really pushed towards the exercise side of things. And that's great, but we need both. If you've got a really tight muscle somewhere, that is going to inhibit your ability to really strengthen other parts of your body, because that's so dominant. So to release that tension in that area in combination with a strength program, you're going to get the best of both, because what you often find is that muscle is tight secondary to some other weakness. So if you release that, then you can get strengthening of the other muscle, and strengthening of the other muscle will mean that the muscle that keeps getting tight says, oh, someone else is doing the job. I don't have to work so hard. I'm just going to relax. And lo and behold, that strengthening exercise is now also a release exercise. So it's that beauty of the way your body works in synergy that you want to tap into and optimize. And as a therapist, if you're able to do that, you reduce your own workload significantly by sort of trying to figure it out first.
So I have a question about manual therapy or massage. There's so many things that you can do. And I've seen so many in the last several years because of my situation. And I noticed, I don't know if this is just me, but you can feel the energy of the other person, how much they're putting into it. I feel like there's sometimes I'm like, oh my God, I'm receiving her energy. And it's just so healing, just that energy, no matter what she does, because she's so into it. It's usually a female, I have to say. I mean, not that doesn't happen with males, but is there any evidence of suggesting maybe it's placebo or maybe it's the energy field that you're getting from somebody? It sounds woo, and I know you have your own clinic but you have experience with this. What do you think?
Well, firstly, you can ask any cynical doctor, cynical therapist, cynical scientist, and they will all have to agree with you that placebo is extremely effective. Extremely effective. And that is taking the pure scientific clinical data approach. So that in of itself, if it's placebo, it's still working, right? So that's the first thing. But having said that, let's pretend it's not placebo and address it from a more scientific perspective. Touch is a very, very strong healing mechanism. You know, we were hunter-gatherers. We raised children in tribes. We were community. And you know, if you read Sapiens, Yuval Harari is one of my favorite authors. But if you read by him, the reason why humans are at the top of the food chain is because we actually did things in communities and did them together. So the way we live our lives now, there are a lot of single, let's call them modular, compartmentalized beings, which is very sad. You know, if you don't have a partner, they're not touched. Or they may have a partner and still not touched for whatever reason. And a lot of elderly people who've lost their partners or don't have family nearby, there's a really huge gap in that physicality of what humans used to be. And obviously there's community rules. We don't touch young children and all these other things. So I think there definitely is a healing component of touch where people feel relaxed. But there's also lots of trust issues as well. Not issues, but just general trust. It's the psychological research shows that if you have a waiting room with a large sofa and there's 5 people, they will not sit 1 meter within the 1 meter of each other. They just won't. It's a personal space barrier. So when you give your trust to somebody and when you're a bit vulnerable, you're not wearing all your clothes and you allow someone to touch you, that you're in a state of relaxation in a way anyway. You're more open to healing. And then if you have a skilled therapist who can, you know, read someone's body language and read their tissues, where they're tense, where they're tight, apply an effective, appropriate level of pressure to release, but not so much that they're, you know, then reacting and tensing up and then going into sympathetic drive, which then tenses them up even more. A good therapist can sense that and help them down regulate and getting the participant to participate by, you know, I often get them to focus on the area I'm working on, work with me, breathe, let it go. I'm not going to push any harder and just focus on letting that go. And that activates their central nervous system to let it go. And then as a therapist, you can get more deeply into the tissue. So I think from just a tissue scientific perspective, it does many, many things, great things. And we all have lifestyles that are not as mobile as we were designed to be. We're supposed to be hunter-gatherers, eat a lot, hunt, sleep. You know, this move around, build a bit of a shelter, move around again, whereas we're mostly stuck in front of computers these days. So we do have a lot of structures that are tight and need that sort of work. From the more sort of, I think you were trying to get at the energy sort of side of things, you know, I think that we have more than 6 senses. I think we have a 7th sense, and over history and time and science and whatever else, it's kind of been drummed out of us. Now, There are studies that have been done on highly trained Buddhist monks in Tibet or wherever else, and they are able to sit out in minus 25 Celsius degrees, freezing in a wet sheet, and they're steaming, and their heart rates are down to like, super, super low, which you would not think is physiologically possible. But because they have such awareness and control of their body systems and whatever else. So if you did extrapolate that to one step further and say, do we feel other people's energies? I think we do. Now, is it actual energy? I'm not sure what the word is. I guess it's like feeling faith. If you're religious in any way, you feel a faith. Is that energy? I don't know. So to answer your question, there's nothing to measure it. We don't have the tools to measure it, but I personally do think it exists, and more or less in different people.
I was thinking using hands and manual therapy versus, say, a robot. Why can't the robot do the whole, AI and technology? But I would say maybe can do so much, but I kind of wonder if the heat from a finger or, the blood flow that comes with, I don't know, some energies that we have, can that be replaced?
Well, the answer is no at the moment. And if you read all the AI and tech books, with the leaders of the world, the Ray Kurzweils, the Peter Diamandis, all these guys who are well progressive in their thoughts about this area of AI and tech, is that I think they all agree there's two vestiges that still have not been approached or been able to be broken or foreseeably changed by AI and tech. And the two are my job specifically, so manual therapists, and the other one is aged care, because both are so specific, so nuanced, and not commercially scalable. So there isn't the incentive for them to do it. But even if there is, the robotics is, as you said, it's not up there yet, and that's quite a way away. Now, will it develop? Probably, but at this point, to your point, it's too humanistic, rather than robotic. Yeah.
Heck yeah. Interesting. Okay, let's move on to the last few questions. I am 57 and starting to have aches and pains all over, particularly my hips, and my right arm is not able to rise above my head. How do I know if this is a menopause hormone related issue or if it's frozen shoulder or the start of hip osteoarthritis? What steps do you recommend I take? I already am on hormone therapy for the last few years, but maybe my dosage isn't high enough. That's the end of the question.
Okay, so there's a few things there. I'll try and be quite quickly. So hip pathology is quite easy to diagnose in terms of X-ray, a simple X-ray. You don't even need an MRI necessarily. That's the first line, gold standard, cheap, effective, and you'll be able to see quite easily at a fairly accurate level of whether you have hip osteoarthritis. Gold standard would be MRI. So if one can afford that and has access to it, then that would be the next step. Now, I would also say that with caveat to that is that early stage hip pain that has not been so bad or long enough to cause damage to the tissues will not show up yet, even though it is actually hip pain or hip biomechanical problem. So that's the hip one. Now, in terms of frozen shoulder, the prevalence of frozen people use frozen shoulder generically for painful shoulders, particularly if you're above 50. Whereas, in fact, the most common shoulder problem is what we call a rotator cuff tendinopathy, which is where the four little stabilizing muscles called the rotator cuff of your shoulder have some issues, wear and tear, and that prevalence is about 30 to 50% of people above the age of 60. So that is actually the most common, rather than the frozen shoulder. The reason I make that distinction is that a frozen shoulder, or the medical term is called adhesive capsulitis. That is of in itself a disease process that's very different to rotator cuff. Now, rotator cuff you can ascertain and diagnose through an MRI. So again, that will rule in or out. Now, the caveat to that, though, is that many people have rotator cuff issues and a lot of people have no symptoms. So it doesn't necessarily mean you hang your hat on it. It's directional in that to say that you have rotator cuff. Whether it's that's causing your pain is another matter. So that needs a skilled therapist to ascertain that. Whereas a frozen shoulder is the diagnosis is actually through usually hindsight of a therapist who has treated it like a rotator cuff, but it's not responding. And how you know is that a rotator cuff pathology has distinct phases of disease progression. So normally it's 3 phases. Normally each are 2 to 3 months in equal length. If it's 6 months, that's a not so great one, but it can be. But the disease process is equal length. So the first 3 months or thereabouts, people always complain of just some general pain, and it's painful, but it's not terrible. And I'm getting a little stiff, but not too badly. And physio is not very effective and often stirs it up without it getting much better. Then you get into the second phase, and that's when you get into much more the inflammatory phase. And it's very painful, often sleeping at night, can't move it, getting really restricted now, and nothing that they do helps. In fact, it always makes it worse. That burns out after another 3 months, and then you go into what we call the stiffness sort of phase, where the pain isn't as bad, but geez, I can't move it above my shoulder, or I can't move it very much. Now, at that phase of the progression is where physio or manual therapists are going to have more input, because at that point, the inflammatory phase is usually starting to burn out, and we can do input with effect as opposed to just stirring them up and not being very effective. So, in summary, it's very important to diagnose which one of those things are. So with the hip, X-ray MRI, shoulder, if it's a rotator cuff problem, which is mainly an issue, an MRI is the gold standard. If it's frozen shoulder, MRI may show some, it will probably show some rotator cuff, but it won't diagnose it as a frozen shoulder. That's a clinical questionnaire kind of baseline with the patient. And the prevalence of that is actually quite low. It's only 2 to 5% in sort of 40 to 60-year-olds. So not that common. But as a physio, once you've seen one and you remember the hallmark trades, you kind of can identify them a bit earlier, hopefully. So in terms of the hormonal therapy, I think what should I do? What's the approach? I think that's the really important approach, because depending on those diagnoses will determine what your treatment is. Now, hormone therapy is, I think, really important, and individualized programs and whether you should or should not should be discussed with your health practitioner or your doctor. But I think hormone therapy, as I think we've talked about this before, got a really bad rap for a number of years for various reasons. But most of that has been revised and is actually more now recommended for treatment of the vasomotor side of symptoms of menopause. But in my specialty of, let's say, physical health and bone health and things like that, if you have no other, side effects or comorbidities don't allow you to have it, I would strongly recommend it, particularly if there's a history of osteopenia, osteoporosis in the family, or it's really impeding your ability to remain active and fit. Exercise is probably, the biggest preventer of nearly all diseases known to women and men. So where in my life, whatever I can do to get you out there and exercise, that's what we're doing. So I think hormone therapy is very important. It helps with your estrogen elasticity, muscle strengthening, joint pain, muscle aches, so it helps with recovery. So in this case, I don't think that her symptoms are necessarily from menopause, although if she has those other pathologies, then menopause may exacerbate the symptoms because you're overall not well conditioned. Now, if all of her other tests come back negative, then sure, menopause symptoms is definitely on the table, but so is, other things then as well. There's autoimmune or, poor biomechanics that they're not bad enough to show on investigations yet. So again, that's where a skilled therapist, I think, is important to help guide you more definitively.
Great answer. There are a couple of things that in my community I've seen help a lot. And because we're all in the menopause space, I've met so many women who had maybe joint pain, their fingers or their shoulders, and the hormone, they report back to me, the hormone therapy really helped a lot. And then the other thing that I see popping up a lot is removing gluten from their diet. And that's people say, or sugar. Some people say sugar, some people say gluten. So I've seen women really having positive effects with their joint pains with the right diet. And just to add on to that, so again, another avenue to try.
Yeah, no, absolutely. And a common joint pain are hands and fingers with menopausal symptoms, but other joints can be affected as well. Muscle soreness and ache. And I would say I haven't seen any clinical data to support this, but in my just kind of clinical experience is that with menopausal muscle pain and joint pain, it's often diffuse and it's kind of not necessarily aggravated by certain things, or it definitely is heightened when I do a hard workout and I don't recover as fast, things like that, rather than my right thigh or my right shoulder. It's usually a little bit more diffuse, just from my sort of subjective experience of patient stories.
Do you know anything about blood flow restriction?
Yes, I think it's very good.
one of the members of my community had what she called quote unquote frozen shoulder. And again, I don't know her very well and what exactly the situation was, but she said for years she was trying to help it. And she bought the Katsu bands, which is the blood flow
Mm-hmm.
restriction. It
Yep.
has a
Mm-hmm.
cyclical mode. And she
Mm-hmm.
said
Mm-hmm.
immediately it worked. And she was convinced that that helped bring her shoulder range of motion back. And I never knew about this for actually this kind of situation. It's more about hypertrophy and maybe blood flow or
Mm-hmm.
something. But
Mm-hmm.
can you explain what if that is
I think, yeah, look, I think in that case that doing the restricted blood flow helped with her ability to train her muscles and move her shoulder. And if it was a frozen shoulder and she's had it for years, then she was already in the way, burnt out. She's just really stiff and needs to get those tissues going. So if the restrictive bands allowed her to move, then she would have broken up some of that scar tissue, got it moving, the joint gliding, and with movement, you get joint lubrication. So in an indirect way, the restrictive blood flow bands did help, but not maybe necessarily as the direct link of, oh, I use these, my shoulder gets better.
Yeah.
So, so an indirect mechanism of effectiveness. And we've got to be quite clear in science with that, because we still don't know actually the mechanism of how smoking causes lung cancer, but we kind of know it does. But we can't actually say it goes from smoking to lung cancer because we don't know all the exact mechanisms, because a lot of people smoke and don't get lung cancer.
Yeah.
So that's why I'm clear with my explanations as to how one thing would work. And I think it did in her case, but just be clear about what the mechanism maybe potentially was.
Yeah, that's what I was trying to find out. I was like, I don't know how, but yeah, thought you'd know. Okay, let's meet the last question, which was mine. And
yes.
I had a total hip replacement. This is 4 weeks ago. The surgeon told me that I now have the operated leg longer than the other. Thank you very much. He says the pelvis evens out over time and to not worry about it, particularly since we are operating the other one. I walk like a duck. It feels totally strange. And I'm worried if it doesn't even out soon, I will start to have other problems from the imbalance, like my back or my shoulders. So what are your thoughts?
Well, you're still early post-operatively, and I think we had a brief discussion before we started this recording, and I asked you what approach you had, like which anterior, lateral, posterior, or minimally invasive, or all the various options. And the reason why I asked that is to know the extent of what muscles were or were not cut. And most commonly one done is posterior, which has the highest rate of posterior dislocations post-surgery. It doesn't mean it's high. It's just highest, right? And on the opposite end is the anterior approach, which has the least sort of risk of that. And they move muscles rather than cut them most of the time. And now, which one is better? That will really depend on the surgeon. And the hip replacement's around for so long that if a surgeon's really, really good at the posterior approach, but not so great at the anterior approach, then go with the posterior approach, because that's what he's good at. So in any event, I think that's the first consideration. Now with the posterior approach, they often cut what we call the external rotators of the hip, which has some of the glute muscles, and they're really important. Now, when they cut them, they don't just leave them flapping. Obviously, they re-stitch them back and they do heal. So, it takes 6 weeks for any full tissue healing to occur. So your 4 weeks, a lot of healing has occurred. But, muscle atrophy or wasting happens within 24 hours. So, by not having a good hip to after the surgery, even when the muscle's weak, you will have lost a lot of strength. So my first question would be, is the imbalance in your pelvis just due to weakness and a traumatic inhibition of these muscles that hasn't woken up yet to support you? So that's my first question to ascertain. The second one would be, how much of that is pre-existing comorbidity? And in fact, the uneven pelvis was the thing that caused the wear and tear of the hip in the first place. So in which case I would treat that with manual therapy, and also as part of that, assess your glute function, your pelvic floor muscles, your abdominal core muscles, your back muscles, all the core muscles, to make sure that pelvic girdle is well supported, to then be able to do glute strengthening exercises. And I think you also mentioned, as part of our just brief conversation, that the surgeon mentioned that your glutes and hip muscles were really tight, surgically speaking. That raised a little red flag to me, because and I'm sure everyone's telling you strengthening glutes, strengthening glutes, strengthening glutes. And that is, and that is correct. That is true. But I think I explained before that our body works in synergy. So when you step forward, for example, and you put weight on your leg, a certain number of muscles activate and a certain number have to switch off for that synergy to balance to occur. Now, if one group of muscles are just really tight and always on, then another group of muscles can't work properly or at the correct moment in time. So under these circumstances, you get this asymmetry. And even though you try and do strengthening exercises, your ability to maximize those exercises is not good, not efficient, and not optimal because those muscles are already tight. So in that regard, we want to actually use manual therapy again to release the muscles, stretch out some of that scar tissue, desensitize that scar tissue so that your brain doesn't feel pain so much. And at the same time, start you on a graded, appropriate level challenge of exercise. So for example, if you want to strengthen your glutes, everyone does deadlifts or squats and all these things, right? And then you might be in a stage in your healing of the surgical technique that you're okay to do that. But my question is can you do that with the way we want? And if the answer is no, then we need to back down and do exercise at a level that are appropriate for you, whilst maintaining that tissue suppleness so that it doesn't dominate the other guy. So we're always just basically trying to keep that synergy between tension and stimulation of the right muscle group to support your hip and pelvis. So that would be what I would really want to approach. And definitely I'd be keeping an eye on the rest of your body to make sure that they stay in good shape. But really, I think fundamentally, again, that your body's hard driven to do the right thing. If you address one of the core issues, and in this case, clearly it's the hip, then the other things will unwind. And with the second hip surgery, again, clearly I don't know your specifics and I've not seen your films and I'm not an orthopedic surgeon and they obviously are very experienced and know what they're doing. But I would say this, in my own clinical experience of nearly 30 years, that people who've had both hips are terrible, usually one's worse than the other, but let's say both are terrible in terms of their films and they've had pain, is that often the second one doesn't need to be done when the other one is great, because now you're loading more effectively. And so often the second one doesn't need to be done. Obviously there are times that it does, but I would say in 3/4 or more of my cases, the second one doesn't need to be done.
Yeah, that's a high rate, which I didn't expect at all. And I know there are other people listening who are who are in the same boat. And when I searched through Facebook groups and hip replacement groups, I asked the question, well, has anybody else got a leg longer than the other? And actually there were plenty of responses. It was a big group of 25,000 people. So you get some, everybody responding. Some people, I think most people said it did even out. The others say like 9 months out, I'm still, like this. I don't want to be 9 months out and still out of balance. But the surgeon did say when you get those glutes firing again, when then it should also, the pelvis sort of gets back into place. Helps. I'm working with physio. I'm doing the manual massage, which feels so good. Just break up that scar tissue and get the scar, nice looking as well. It's got plenty of machines. I don't even know what he did something yesterday. It was like a laser something right on the, I don't even remember why. I asked and I can't remember why he said to use it, but it was just after my physio.
It's probably to promote healing. I think that one thing you mentioned before about nutrition, and in this case, it's quite pertinent as well. Clearly, you're trying to build muscle. You're a woman who most women and most people don't eat enough protein. So actually, as part of your active rehab, you got to ensure that you have enough protein, because if you don't do the work, then if you do the work but you don't have enough protein, you're not optimizing your muscle building in any event. And in fact, I listened and read a couple of interesting research by an exercise physiologist, I think she is, but she's well published, Dr. Stacey Sim, I think her name is. And she was mentioning that basically all the sort of when do I have protein, before, after workout, during, all these things, they're all been done on males mostly. And in fact, and I don't know where this study particularly came from, but she basically said that for women, if you want to optimize your training and muscle building, you need 15 grams of protein before you work out. And we only have 45 minutes after workout, again, to consume some protein to optimize our training. Now, for men, apparently, they have 3 hours. So unfair. They have a 3-hour window, whereas women, we apparently have 45 minutes. Now, I'm saying this off the bat of what she's researched, so I haven't read the data myself to support that. But I think that's whether it's low-hanging fruit. So if you can have 15-gram protein shake before you work out, another 15 grams when you finish workout, it's not that difficult. Have a boiled egg or something. To further maximize.
I agree. I love Dr. Stacey Sims. We've had her on the podcast
Mm,
before, and I went through her menopause for athletes course. So I learned a
mm,
ton
mm,
about that.
mm,
And I have since been, doing, getting some protein before my training. Well, not so much anymore because I'm not training, but when I was definitely doing
mm,
that and then getting it in right
mm.
after. That being said, I can't remember what podcast I was listening to, but it was with another exercise physiologist who looked at some new research coming out. And I got to go back and find this one because I want to go look at that research, was saying, actually, it doesn't matter when you get it in, just get it in. And throughout, if you got to get 100 grams or 150 grams per day, like just get it in. I personally tell people don't bookend everything in the end. I like to space it out. Again, I think if you can't do anything, just get it in. Like make your life simple. But if you can, like we
Exactly.
would like to optimize, we try to optimize,
Hmm.
then maybe,
Hmm. Hmm.
we can play around with those things. And
Hmm.
again, what is your truth? And that's what biohacking is all about, is just let's figure this
Hmm.
out, what works for you best. You can always measure this,
Exactly.
right?
And this is the thing with nutritional studies, they are the hardest to do because no one complies fully for long enough time for an RCT to be really effective because you know what you're doing, because you know what you're eating. And everyone's biochemistry is different. So I think the underlying score for that is basically ensure that you get enough protein if you're
Yeah.
working out to optimize your muscle building. Really, that's the bottom line. Whether it's 15 minutes before or 15 minutes after, whatever, just get it in.
Just
Yeah.
get it in. Oh my gosh. I'm
Mm.
so happy we had this conversation, Panda. You've been
Yes, it's
so
been great.
informative. And where can people find you if they want to know more?
Well, obviously, just a Google search. I have a clinic in Hong Kong in Central, and it's called PhysioMotion. We also are a part of Yun Wellness and Island Shangri-La in Hong Kong as well. So we do a lot of their women's health programs there. So I'm on LinkedIn, Instagram, the usual. Although I must admit, I'm not the best on social media. I do try my best, but it's just a matter of time. So that's where they can find me.
Oh, great. I'm going to have links to that in the notes below. And one last question. Are you doing the online telemedicine or teletraining?
Yes, I absolutely can. Yes, absolutely can. You just contact us via our WhatsApp or email or call us, and we'll just book it in like any other session. And I'm happy to do telehealth consults to navigate these sort of pathways. Yeah.
Great. Okay, Panda,
Yes.
I'm going to let you go. Thank you so much. And I
You're
am
most
just,
welcome.
again,
Really
so
enjoyable.
grateful for your time. Have a wonderful day or night.
All right, then. See you then.